lunch symposium. I hope you all enjoy the UA meeting so far. And we are halfway through, and there's, I think today we have many highlights and good conferences going on. So now we come to the lunch. You can enjoy lunch at the same time and learn something new. So it's my pleasure and my honor to introduce our speaker here. And also we become good friend now, Professor Amberton from London. But probably everyone know him very well because he's really the pioneer in the field of focal therapy. So he has been to Taiwan to give us lecture and teaching us the technique and sharing his know-how. So today we are very happy that he come back again to Taiwan and willing to share more information. So I will not delay the meeting. I'll let Professor Amberton to start his sharing. Yeah, thank you.
Great. Well, it's a pleasure to be here. I'm surprised you got a voice after all that singing last night that you did. Yeah. So we got three excellent talks, but hopefully today we'll have time for a discussion. Those of you that were at yesterday's meeting, the talks overran a bit and there was no time for discussion. So we'll try and get through the talks on time. Po-Fan, would you like to begin your talk?
Of course.
Yeah, very good.
Okay. Hello, everyone. I'm Po-Fan Xie from Taiwan. Today, my topic is preparing the ground infrastructure requirements before focal therapy with HIFU. Okay. And as I know, radical P has long been the standard of care for prostate cancer. But with the advance of image, we can use focal HIFU. It uses MRI to guide the ablation zone, so we can treat the tumor and spare the urethra, nerve, or sphincter, so we might achieve a better functional outcome. However, a successful HIFU depends not only on the HIFU device, but also the entire infrastructure. And here are some key points, including the MRI, fusion, biopsy, MDT tumor board, and post-treatment follow-up. So let's start with MRI. And today we always use the PIRAS to read MRI. And the aim of the PIRAS is to standardize the acquisition, interpretation, and reporting of MRI. And it was first proposed in 2012 and has been updated in order to improve the diagnosis ability and decrease the inter-reader variability. And it assesses the risk of cancer on a scale from 1 to 5. A higher score of the PIRAS means a higher risk of prostate cancer. So using the PIRAS, we are able to locate the suspicious area and assess the risk of cancer and determine the need of biopsy or not. However, before reading MRI, we must have a well-quality control. Otherwise, MRI might become unreliable, and the outcome of HIFU would also be compromised. And actually, the quality of MRI would be affected by many items, including the vendor of the scanner, the age of the scanner, 3T or 1.5T, and besides, the experience of the radiologist also plays a very important role. And also, we have to note the bowel peristalsis, rectal distension, patient motion, and biopsy-associated bleeding. So, in order to standardize the quality of MRI, a scoring sheet called PIQUA has been proposed. It assesses the quality of T2 weighted image, DWI, and DCE. And if all three are of good quality and there was complete adhere to the PIRAS, it would be score 5. And you may ask, which score is acceptable? Well, in our hospital, in our place, we only accept score 5. If the score is lower than 5, we would always rearrange MP MRI. And this is based on the global prime study. It shows that initially only 32% of the scanners would be of PyQuad 5. However, after a quality control, up to 97% would be of score 5. So we should always assess the PyQuad score before reading the PyRAS score. And last year, a second version of the PyQuad has been published. It can help us to assess the quality of not only MPMRI, but also BPMRI. And it also simplified the scoring into 3 points, so we can assess the quality of MRI more easily. And the interpretation of MRI really takes some expertise. And this paper showed that the PPV of MRI ranged widely across different hospitals, implying a different level of experience in the MRI reading. So we must strongly ask our image staff to have a well-trained, certified training of MRI, and we should have a peer review of the quality of MRI. And this is a consensus statement by the European experts. And in brief, they say that when we start to establish the MRI protocol, we should call for help from some experienced specialists. And we should always follow the standards of the PyRAS and keep updated. And we should review the quality of MRI by sampling every month. And we should hold a MDT tumor board meeting. And the second issue is MRI ultrasound fusion biopsy. Even if we had a high quality MRI, when we started to do the MRI ultrasound fusion, we might still miss the target up to 51% because of the immature fusion biopsy techniques. So this paper shows that we have to do at least 100 cases so that the cancer detection rate could reach a plateau. And this is our own experience. We show that with accumulated case, the cancer detection rate could increase and the Gleason upgrading rate could decrease. And we must be able to locate the tumor and assess its Gleason score precisely so that we can start it to do focal therapy. So never rush to focal therapy before maturation of the biopsy technique. In other words, the Gleason upgrading should be lower than 10%. And always validate your biopsy data and MRI using the RP specimen for the initial 50 to 100 cases. And another issue is that MRI might underestimate the tumor area, so we can take additional course around the target. And some papers show that taking additional course around the target can help us to better estimate the tumor area, and we can also determine the best treatment margin during HIFU. And another small tip during the biopsy is a freehand approach. And without using a grid, we can get a better control of the biopsy needle, and we can also reduce sampling of the transition zone. And some papers have shown that using a freehand approach, we can detect more cancer using a lower number of cores, and we can also do the biopsy more quickly. And nowadays, there are many platforms for us to do the MRI ultrasound fusion biopsy, and they may differ in the way of ultrasound image acquisition, biopsy routes, or how to track the image, or rigid or elastic registration. And you may ask which platform is the best. Well, there is no standard answer, and there is no head-to-head study. But in my opinion, as long as you get familiar with any one of the device, you can do it well. And please always keep in mind, the soul of biopsy is the quality of the MRI, not the platform. And the third issue is MDT tumor board. And this study highlights the value of MDT tumor board in determining the focal therapy candidates. And in brief, in the MDT meeting, we should review all of the MRI as well as the histopathology. And this paper showed that after the MDT tumor board, only 25% of men were eligible for focal HIFU. So this study shows how the MDT could impact the treatment decision to avoid over-treatment and to avoid under-treatment. So what should we do in the MDT? The key is to correlate MRI with histopathology. And this is a quality improvement in Duke. It shows that we should compare the MRI image and the biopsy specimen and RP specimen. If there is any inconsistency, we should try to review the quality of MRI, and we should try to see that if there is MRI reading error. And we have also to review the biopsy video to see if there is any registration error or targeting error. And we should also try to find out if there is any false positive finding on MRI or any MRI occult tumor. And here I have to emphasize that the experience of the MDT tumor board must be built under a long-term collaboration. And this is our hospital experience. And since 10 years ago, we have assigned a fixed doctor to read all of the MRI, a fixed doctor to read all of the biopsy or RP specimen, and a fixed doctor to do all of the fusion biopsy. And we have a MDT tumor board meeting every 2 weeks. And in this meeting, through the patho feedback, we can improve our experience of the MRI reading, and we could also improve our biopsy techniques. And the last issue is the post-treatment follow-up. And this is a consensus statement by the Focal Therapy Society. It shows that after HIFU, we should check PSA every 3 months, and we should arrange MRI on the 6 and 18 months after HIFU, and we should arrange a routine follow-up biopsy on the 6 and 12 months after HIFU. And we should also use the IPSS or IIEF to check the functional outcome. And the key is to record any in-field recurrence or any out-of-field recurrence to see if there is any salvage treatment and any adverse events. And if there is any in-field recurrence, it means that we may have an MRI underestimation of the tumor area, or during HIFU, we may have some targeting error or improper energy. And if there is out of field, it means that we may have an MRI misinterpretation, or the quality of MRI was not so good, or there may be some MRI occult tumor. And last, according to the current EAU guideline, HIFU should only be done in a trial so that we can have a well quality control, and it can also help us to do a research. And in the future, we may have an AI-based interpretation of the MRI, and we may have a real-time ablation feedback on the HIFU device, and we might be able to integrate the genomic data with MRI to do a better risk stratification. So in conclusion, infrastructure for focal HIFU include a high-quality MRI, a precise fusion biopsy, a dedicated MDT tumor board, and a strict follow-up. And adherence to each layer contributes to a safe, effective, and patient-specific cancer care. Thank you.
Thank you, Professor Xue. So now you're going to give down. Okay, now I think we will save the Q&A later on. So we will continue the presentation. So next, I would like to invite Professor Abberton for his presentation. So the evolution of HIFU, past, present, and future. Thank you.
President and Chair, thank you very much indeed for organizing such a wonderful meeting and for yesterday's wonderful dinner. In fact, at the dinner yesterday, somebody sitting next to me was saying, I think the implementation of focal therapy has been very quick. And I said, that's funny, because I think it's been very slow. So you can all make up your own judgment on that. And this is a reflection on the last kind of 15 years or so. And you could say that actually not much has changed. This is a paper we published 12, 13 years ago on patients that were treated 15 years ago. And you can see everybody was continent. 95% of men kept erections sufficient for penetration. And there was a 95% rate of freedom from disease, albeit in a very small cohort over a very short period of time. But this was over a decade ago. And now we have wonderful work from Japan showing exactly the same results in a bigger cohort, in a different hospital, on different groups of patients. And you can see, if you look at the bottom there, the radical or systemic treatment-free rates of 96, 94, and 95%, depending on the risk profile. Very, very similar results to the ones that we were obtaining 10 years ago. And this work has shown that actually with today's risk stratification methodology with MRI and PSMA PET and targeted biopsy, none of which was available 10 years ago. Well, MRI was just about, but the other two were not. That actually there's very little difference in outcome, albeit over 3 years, as defined by baseline risk. And of course, the functional changes that Japanese patients experienced when treated looked very, very similar in profile to the ones that we did. This is very important. This is consistency. This is repeatability. This is showing that the same treatment can generate exactly the same results on different sides of the planet over a decade apart. And if we come right up to date, we can see that the French have done a very big study with thousands of patients, not a randomized study, but comparing. Of course, we didn't have comparisons, in 2012. Now we do, and I'll show you a randomized study, or at least a report of a randomized study in a second. But this is trying to compare, managing the baseline characteristics of surgery versus HIFU, and this was kind of discussed yesterday. In terms of cancer risk, the HIFU and radical prostatectomy patients look quite similar. In terms of comorbidity, they look quite different. HIFU patients were much less likely to be ASA1. So clearly there are selection criteria going on here. This is, I will say again, a non-randomized study. But you can see in terms of kind of cancer profile, very, very similar. And what is amazing is that over the period of the study, the outcomes were very, very similar for prostatectomy versus high-intensity focused ultrasound, which was done here at whole gland level and focal. And interestingly, and as expected, given the data that we had, the side effect profile and the tolerability of HIFU was much better in terms of urinary continence and overall genitourinary function, which you can just about see there if you have good eyesight. And this was presented at the AUA. It hasn't yet been published. This is the Norwegian randomized study. Again, a very impressive attempt to randomize. They had the same problem that everybody has when they randomize, is that when men are randomized and allocated to prostatectomy, a large proportion, 1 in 4, is pretty constant, say, no thank you, I will have HIFU, or I will not have prostatectomy. And this is the crossover that they saw. This is an intention to treat analysis. When the paper's published, I suspect the debate will be about whether it is possible to do an intention to treat analysis when 1/4 of patients refuse their allocation. But nevertheless, this was done. It was done in great spirit, and the intention to treat analysis that was presented showed failure rates for focal therapy of 6.5%, versus failure rates of 8.5% for radical prostatectomy. Now, obviously, you fail differently depending on the treatment that you have. and that has to be incorporated in any study. And this was a non-inferiority approach. So this is just asking the question whether HIFU or focal therapy was non-inferior to surgery. And of course, once again, it was better tolerated, as we can see on this slide. So we look forward to seeing this paper. Hopefully it'll be published in the next month or so, and we'll get a chance to see the results in great detail. But the reception of this over time has really been interesting, and the fact that there are so many of you here today is wonderful. 10 years ago, the room would have been fairly empty. There would have been a few enthusiasts at the front of the hall, and there was a lot of skepticism at the beginning. Quite right, when we started putting grants in and started saying that we wanted, to ethics committees, etc., that we wanted to not treat the whole prostate. We wanted to treat a little bit of the prostate with the tumor plus a margin. But it's funny that how quickly things change and how quickly, and this is obviously a response to the paper I just showed you initially, once people see success, this is the Medical Research Council, one of the big funding agencies in the UK, thought this was a fantastic news, and they of course wanted to now back it if we could submit a trial. Some of you, some of the older, more senior people in the room will know of Patrick Walsh, will have been to his teaching sessions at the AUA, huge important figure for the last century in prostate cancer. He wasn't too keen on focal therapy. And indeed, in response to the paper I showed you earlier, the 2012 paper, he was very disappointed that a Lancet journal would permit the authors to conclude that these patients were actually free of disease and for the authors to fool the public into believing it. And his challenge to us was that we were assessing status based on imaging to a large degree. Obviously, that trial did also involve a biopsy, but he was very worried about the use of imaging in selecting patients and also in using imaging to declare whether or not they had had a good result. And then, of course, slowly, opinion slowly changes, lots of consensus meetings, guidelines start to change their view, more and more papers get published, and eventually in April 2023, NICE, the National Clinical Care Excellence in the UK, basically said that HIFU was safe, and you could do it, and again, ideally within the, using a registry so that you could follow outcomes, and with the appropriate consent for a relative new procedure in which the outcomes were not, in which the long-term outcomes were not clear. And this has allowed many other guidelines to now shift and reflect that this is a now safe procedure that can be regarded as prime time. But it's been a long journey. And interesting, when we talk about focal therapy, there are lots of types of focal therapy that we talk about. And if you look at, so top left was the focal therapy that we were doing before MRI. We were treating anatomically. We could all agree where the midline of the prostate was, and we would treat to the left of the midline until we ran out of prostate, or to the right of the midline until we ran out of prostate. And the disease was identified through 5mm template biopsy. These were very hard to recruit to studies. Everybody, or not everybody, but many patients had 1mm 3+3 on the other side. They were deemed ineligible. And the paper we published in 2010 took a long time to recruit because it was based on a 5mm template sampling. Once MRI came in, and I think it kind of rolled in, 2005, 2006, 2007, 2008, and of course got better and better. Once we had confidence, we could move to the middle here, top middle, and identify a tumor and treat it with a margin. So this is not anatomical. This is a treatment based on the tumor, completely individualized to the patient's, not the patient's prostate, but the patient's tumor. And obviously this was verified by sampling. And then, so when we were doing that, we also insisted on no disease anywhere else in the prostate by 5mm template sampling. Again, took a long time to recruit. And then the thinking about Gleason 3+3 started changing. Many of us were publishing papers saying we don't think Gleason 3+3 is cancer. That's become fashionable again now. And so we started tolerating small amounts of disease that we could not rule out when we were doing a 5mm template sampling. So the kind of disease that would be systematically missed when you were sampling the prostate 5 millimeters apart. And that essentially was 3 millimeters of Gleason 3+3. And that allowed us to kind of tolerate small amounts of disease that was picked up randomly that we couldn't rule out with the best test that we had. And then that allowed very quick recruitment. And so we could treat a man with a lesion who also had a tiny bit of Gleason 3+3 on the other side. And then you can see how it evolved. And eventually there have been studies allowing multiple, people with multifocal disease. And we're probably here now treating the major lesion and then maybe thinking about some form of therapy. It might be immunotherapy, it might be finasteride, it might be, 30 grays of radiotherapy to kind of manage the rest of the prostate over time. And this is the kind of probably where we are now. So this is the kind of whole story of focal therapy. But it's only been made possible by improvements in imaging. This was MRI in '82. You can't basically not see the prostate. This is 2005. I think we can all see that there's a tumor on the right. This is the exquisite imaging that we can get now. You can see very tiny tumors. This is 0.1 cc. It's not even that actually, but it is a cancer. You can see it there on the diffusion and the gadolinium scan. This is probably the earliest that you can detect a viable tumor mass, a prostate cancer. And the other thing that's been happening in the background, in parallel, that actually validates the focal approach is this understanding of visible disease, i.e. lesions, what I call viable tumor masses, versus the disease that we cannot see. And of course, a tumor needs to do lots of things to go from invisible to visible. I won't read them out, but it has to do all these things in sequence, and if any of these failed, the tumor will not make it to visibility. And I think we're all learning that it's visible tumors that are clinically significant. It's visible tumors that progress. It's visible tumors that metastasize. And that is seen in gene expression, visible versus non-visible. They're quite different in terms of the genes that have been switched on. Also, in terms of the hierarchical clustering, it doesn't look like invisible disease becomes visible disease. They look like two separate entities with completely different gene expression profiles. Again, validating the approach that actually the disease that matters in prostate is the disease that you can see. And so where are we today? I think we all agree that actually focal therapy is about identifying a lesion around which you can get a margin and making sure the patient understands the uncertainties in relation to the treatment. And this is what it looks like today. Nice MRI, lesion in the left peripheral zone. You can see exactly where it is on the Z plane. You can see it on the ADC map. You can see it on the long B sequence. You can see it on the gadolinium. There's not much else this could be. I could add ultrasound. I could add PSMA PET, which I think this lesion would be visible. And then you treat the lesion using image fusion. You create an anterior margin. You treat on the lesion. And then you treat, this is a side view, just treating anterior, and then you treat behind the lesion. In other words, creating that margin that you would require in all other forms of cancer. And just extending the indications, this is a Gleason 4+5 patient, not in the guidelines, but now with PSMA PET and high-quality MRI, we're starting to treat these individuals, particularly in the older man, because they want to avoid hormones and radiotherapy. So you can see this lesion. It was PSMA PET positive, as you'd expect, though no metastases. You can see the pathology there. And this is the MRI a year post-treatment, completely free of disease. The PSA has gone down to 0.9. He's saved himself 2 years of hormones, at least for the moment, and maybe 4 weeks of radiotherapy. He may need it in the future, we'll see. It depends whether he's got microscopic metastases. But you can see the indication now changing to very, very well characterized high-risk patients. And what's going to happen in the future? Well, our ability to characterize disease is going to get better and better. MRI, in terms of post-processing, is going to improve and is starting to recapitulate the underlying histopathology. This is verdict. This is luminal water fraction imaging, a 5-minute MRI scan that recapitulates the underlying histological architecture. This is in trials at present. And in future, and just around the corner, we're going to be able to characterize the disease not by how it looks, but by how it metabolizes energy. So how indeed the cancer generates energy through hyperpolarized MRI. This has been very difficult to do to date, but it's going to be much, much easier in the future. And journalists are picking up on this, and this was published in the Times a few years ago. Mark Porter is a doctor who writes in the Times, and he looked at all the evidence and said, if I had disease and I was eligible, I would want HIFU. So, Chairman, with that, data's accumulating. We've now got multi-center, multi-user experience. Data suggests now that the majority of eligible patients will do very well with a 5-year freedom from progression rate of between 83 and 95%. Take your pick, depending on where the data was generated. You need, as has just been said before, exceptional imaging, true partnership with radiology and histopathology, near perfect risk stratification, much, much better than you need for radical surgery, expert management of energy sources, and commitment to long-term follow-up of these patients. And I think finally, I think it is the defining kind of marker of quality for a good urological unit that they can have a thriving, vibrant focal therapy program. Thank you very much.
Thank you, Professor Everton, for your excellent talk. So I think in this occasion, we are very fortunate to have two very important person in the field of focal therapy and HIFU. Now we heard about the Western's experience. I'd like you to draw your attention to our Asia experience. Especially, we are very happy to have Professor Shoji here. He will share his experience on HIFU, especially these data are all generated in Asia. So without further ado, Professor Shoji, please. Thank you.
Thank you very much for the introduction, Professor Pan. Thank you very much, M. Baton, for the great opportunity for me. Today, I would like to present focal therapy with HIFU for localized prostate cancer, an innovation in treatment techniques and evaluation of therapeutic technologies. This is my COI. So high-intensity focused ultrasound, HIFU produces ultrasound waves generated by a spherical transducer delivering ultrasonic energy to pinpoint 40 millimeters in diameter. So thermal and mechanical effect of HIFU destroys the targeted prostate tissue, and as distinct margin between the treated and untreated area is observed in the prostate treated with HIFU. These characteristics make HIFU an attractive therapeutic modality for focal therapy of the prostate cancer, and this is an aim to cure while preserving continence and erectile function. So this is the agenda of my presentation. So insight gained from foreground HIFU experience. So we reported the clinical result of foreground HIFU at our institution in 428 patients during follow-up with median 60 months. This slide shows the biochemical disease-free survival of the patient treated with foreground therapy using HIFU in low, intermediate, and high-risk group according to dynamic risk group. The disease-free survival rate was 80.4, 65.6, and 61.6% respectively. By the development of the imaging and treatment modality, possibility of the focal therapy for localized prostate cancer has come to be noticed. So HIFU has attracted attention as a modality for focal therapy. So however, we had key considerations in focal therapy with HIFU. So during the treatment, prostatic swellings observed. This truss image was before the treatment and after the treatment for anterior portion. You can see the prostate deformation and prostatic swelling in the sagittal image and axial image. So we measured this prostatic swelling and shift during HIFU. This figure is a 3D model of the prostate. This solid line is before the treatment of the HIFU, and this dotted line is after the treatment. So during the treatment for anterior portion treatment with median 25-minute treatment, median swelling was 18% and the median shift was 3.7%, 7 millimeter. In pathological findings of the prostate cancer treated with HIFU, coagulative degeneration of the prostate cancer tissue involving gland and vessels with diffuse stromal edema was found. So the main reason of the swelling was diffuse stromal edema we found. This slide shows the contrast answer of MRI at 2 weeks after the HIFU. So in the patient treated with conventional method without intraoperative adjustment, you can see the remained blood flow in the anterior portion of the prostate. So deformation of the prostate during treatment carries a risk of the compromising the accuracy of the focal therapy targeting the cancerous lesion. So next, development of technique of the treatment of focal therapy with HIFU. So how can we control intraprocedural prostatic edema? What do you think? So we came up with compression stocking for prevent edema. You know very well this stocking. So we started compress the prostate from the rectum by the HIFU probe and this pubic bone, so intraprocedurally. So we call this method compression method. We compare the change of the prostatic swelling and intraprostatic point shift between conventional and compression method. This picture shows the HIFU probe in compression and conventional method. And in compression method, the balloon was expanded by the water from 80 to 200 milliliter, like this. This slide shows the transrectal ultrasound image during the treatment preparation using the Sonablate device. At first, we insert the probe in the rectum, and expanding the probe like this. And now I adjusted the position of the prostate and the transducer. Very important thing is this is a parallel position, a prostate and transducer like this. In compression method, very good suppressed the prostatic swelling and shift compared to conventional method. So on contrast enhanced MRI at 2 weeks after treatment, all blood flow was disappeared in compression method. This slide shows the biochemical disease-free survival of the patient with HIFU with and without the compression method in low, intermediate, and high-risk group. In all risk groups, the biochemical disease survival rate were superior rather than the compression method, without compression method. Based on result, we concluded that the introduction of the compression method led to improved treatment outcomes. So I would like to summarize the impact of compression method. So compression method suppresses prostatic swelling and shift during HIFU. Compression method reduces the vascular flow in the prostate and helps minimize the heat sink effect. The compression method reduces the HIFU propagation path, resulting in higher intensity at the focal site to promote cavitation. So further, the therapeutic technologies has developed. So using 3D treatment planning, focal therapy can be planned on axial, sagittal, and coronal ultrasound images. Tissue change monitoring can predict interprostatic temperature during the procedure on real-time ultrasound image. So as safety alerting system, early alert of the rectal changes, rectal cooling system prevent rectal injury. So I would like to introduce our clinical result using intraoperative prostate compression method. So inclusion criteria was PSA level was with and less than 20 nanogram per ml. Significant cancer was diagnosed MRI transfusion image guided biopsy and 12 cohort systematic biopsy. No evidence of metastasis. Focally localized significant cancer within the left or right lobe or upper or lower half of the prostate. I show you the movie of the very easy process of the treatment. So by utilizing the MRI transfusion image guided biopsy, this red line is a cancer suspicious region. The target biopsy and the systematic biopsy. So we determine the 3D location of the significant cancer. Next, we prepare the hive treatment using Sonablate device. This is a hive probe. This is a transducer. So in the transducer, this imaging port and treatment port were included. From this treatment portion, the hive was irradiated to the focal area. This is a CG of the treatment. So hive treat, so this significant cancer area and margin, like this. So we define the biochemical recurrence thanks as the definition. Pathological recurrence was diagnosed with MRI fusion biopsy and systematic biopsy at biochemical recurrence. So this is the patient characteristics. The patient number of low, intermediate, high risk group were 51, 107, and 82 respectively. This is the oncological outcomes. The decreased rate of the serum PSA level in low, intermediate, and high risk group was 73, 81, and 83% respectively. Pathological recurrence during the follow-up period was 7.8, 8.4, and 8.5 respectively. During the patient, the repeat focal therapy were received in 2, 5, and 2 patients. Finally, radical treatment-free rate were 96, 94, and 95% respectively. This slide shows the complications. Ulceral stricture 2.9%, UTI 1.9%, urinary incontinence grade 1 at 1.3%, severe erectile dysfunction was 24% respectively. So an improvement in therapeutic outcome observed, but no increase in complication was noted in the compression method, you can see. So finally, I would like to introduce our recent research. So it is difficult to evaluate the therapeutic effect of focal therapy using PSA alone. So we focused on the difference in the sugar chains of the PSA between from normal and cancerous prostatic tissue. LDN PSA is a PSA carrying a prostate cancer associated sugar chain. So if all cancer tissue was treated with focal therapy, LDN PSA, which is cancer-delivered PSA, is expected to be disappear. So using cutoff value of LDN PSA density, 83% of the patients who were diagnosed with pathological recurrence at median 20 months after the treatment already predicted to the recurrence at 3 months after treatment. Based on result, LDN PSA has potential to evaluate the therapeutic efficacy of focal therapy. So next, there is no established method to assess both cancer control and function in focal therapy. So using the win ratio statistical method, patient first compared based on the cancer control. And next, if outcome are comparable, functional preservation is assessed. And to determine whether focal therapy or LARP is the superior result. That process is a win ratio statistical method for the evaluation of the focal therapy. So evaluation using a method demonstrated the superiority of the focal therapy across all risk groups rather than LARP. So, but this is only the 90 patient and a very short period. So this is my take-home message. With advancement in technique and device, treatment outcomes of focal therapy using HIFU have been improving, and the long-term clinical results are promising. We are investigating new biomarkers and statistical methods to evaluate the therapeutic efficacy of focal therapy. This is final slide of mine. So the background of the importance of educational activities to support the rapid adoption of HIFU in Asia. Need to promote data collection and collaborative research on HIFU in Asia to enhance the regional global presence in the field. And desire to strengthen interaction and network among members. So we established the Asian Urological Society for Focal Therapeutic Ultrasound and Focal Therapy. So very, very supported by the Professor Pan, chair of this meeting. Thank you very much, everyone. Thank you.
Yeah, excellent talk. I'd like to invite three of the speakers to come forward. We still have some time. We would like to have questions. Yeah, please, Professor. So.
I'm Dr. Zhou from Taiwan. I have a question to Professor Mark Emberton. Thank you for outstanding the talk. I have a question that we know that focal therapy is the advantage of HIFU. However, it seems not supported by all the AUA or EAU guidelines. So from Dr. Xie's slide, which showed that maybe in the clinical trial or something, do you think there's a way to change the guideline? And at the present time, how to explain that our standard view about the guideline and our belief?
Thank you. Very, very good question. Watching guidelines change over time is a kind of interesting thing.
Yes.
Most guidelines are softening, and you know, when MRI was suddenly NICE were the first to do it in April 2019. This is very, very late. Everybody else followed, AUA, EUA, etc.
Yes.
So I think it's just a matter of time, and you can see them softening. They were saying focal therapy only within a clinical trial.
Yes.
You know, which means that very few people can do it, and now they've include registries in that, which means that everybody can do it. So I think you'll see all of them soften and you know, open out their recommendations.
Okay, thank you.
Yeah, this is next question. Yeah, please.
I want to ask a question for Professor Shoji. I can see you emphasize a lot on the compression method. Can you tell us more about how exactly we know whether there's enough pressure applied, or do you adjust like the pressure between different, like the first treatment and the second treatment during the operation?
Thank you very much. A very nice question, very important question. So at this point, we cannot measure the interprostatic pressure during the treatment. So we just adjust the position of the probe so based on the image of the transrectal ultrasound image during the treatment. But maybe in the future, we can measure the interprostatic pressure using the referral catheter or not. So I will suggest such a research. Thank you very much.
So following this question, so is there a limitation of the prostate size?
No.
If you now know how to use the compression, and
Yes.
also maybe a question to all of you, when you find a lesion in the MRI, but it is in the lower part, regardless how big it is, you can still use HIFU. Any comment?
Thank you very much. So compress is very meaningful to treat. So as Professor Pan said, so for the large prostate, the compression is sometimes difficult, but we compress the prostate as so the possible rate. So, however, if the prostate cancer located in the anterior portion in the large prostate, maybe it would be very difficult to treat, like a compression method sometimes. So that's a limitation of the compression method. Yes.
I agree with you. But I think we're seeing the indications expand. So compression allows you to treat more patients than you could have otherwise. And the other option you have is to shrink the prostate. And I use finasteride and Casodex, 50 milligrams of Casodex for 3 months. And you can normally get a kind of 25 to 30% reduction in prostate volume. Add that to compression, there's a lot that you can reach. The thing that stops you is the pubic bone. I find, in the very big prostates, if you're compressing, the pubic bone becomes very, very close, and it's very hard to treat because you don't want to damage the pubic bone.
Well, I would respond to Professor Zhou's. As HIFU is not a standard of care in the current guideline. So that's what we should do. We should cooperate to publish our data so that we can change the guidelines. Thank you.
Any more questions? I think we still, maybe one more question, the last question, before we close this. Yeah, please. Yeah.
Okay, thank you, Your excellent speaking. I'm from New Taipei City. I'm Dr. Zhou. I'm impressed about the Dr. Shoji. You show we can use LD and PSA for the follow-up of local or any recurrence. In daily practice, we can use P2PSA, also in PHI-5. Do you think we can use P2PSA as a most sensitive index for the follow-up of any recurrence after focal HIFU? Thank you.
Oh, thank you very much. Very nice question. So we have no data which is a good sensitivity or specificity for the detection of the prostate cancer using the PHI or PSA. But the measuring process is very easy for the editing PSA. So because PHI, we should take a blood and in the cold place and measure. So for the editing PSA measurement, directly we can measure. It's a very easy process. That's the advantage. However, your question, which is more good, we have no answer in this point. Yes.
Okay.
Can I ask my fellow speaker a question on that matter, with your permission?
Yes.
Yeah.
Okay.
But obviously your blood test, which is wonderful, gives you a propensity or likelihood of that patient progressing. But you probably still need to see the MRI. Yeah. So you still need to see so it's not sufficient information to treat. You still have to wait, presumably, for the MRI changes to occur to decide whether you can retreat or indeed do a whole gland treatment. Yeah. So just tell me exactly how it benefits patients.
Yes, now an undergoing project is just after 3 months after the treatment using HIFU. So we measure the retinal PSA, so which can predict remain significant cancer or not, which will contribute the interval of the follow-up. This is our protocol.
Yeah. Okay. So this is.
Yeah.
Yes.
Yeah, I think we have lots of learning point here and information. So during this meeting, we know that people are interested in focal therapy. So for those who you still want to learn more, please come back tomorrow. We have another section and we are focusing on how to choose the best method for HIFU therapy or focal therapy. And there is a debate on this topic. So it's a time constraint, so I have to close this section. And once again, thank you very much for the excellent talk from 3 of these experts here. Thank you very much.